Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Standard Medical Notes. So, in the previous video, we have discussed about the theoretical part of the masses which lie in the anterior mediastinum, middle, posterior mediastinum, and the cause of unilateral hilar enlargement and bilateral hilar enlargement. These things and the differential diagnosis. In the anterior mediastinum, it was fortis, thymoma, thyroid, terrible lymphoma, and teratoma. In the middle mediastinum, it was the visual structures like um, most commonly it was lymphadenopathy, okay, lymphadenopathy or aneurysm of the aorta, okay, and hiatus hernia. These were the important differentiation. In posterior mediastinum, it was related to the nerves, so any neurogenic tumor or spinal infection in the form of abscess or Pott's disease. Unilateral hilar enlargement mainly seen in uh, lung cancer and infection like tuberculosis. Okay, lung cancer, malignancy, and infection. Bilateral, usually commonly seen in sarcoidosis and lymphoma. Let's see the images of those, the signs of those in the chest X-rays and confirmation by the CT scan. Let's begin with the name of Almighty. So I need to rub this theoretical part. So let's see the first one. So you can see here there is a mass in the mediastinum, and if I draw line, so this angle is obtuse, so that means it is a mediastinal mass. And the second thing is you are able to see the vessels. If I zoom it in, the vessels emerging from the left carina, you are able to see, you are able to make out the vessels. That means the hilum overlay sign is absent, so that means the mass is either in the anterior or posterior mediastinum. So let's see in the lateral chest X-ray. So if you see, so if this is the heart, this part, this is the heart, so it is lying anterior to the heart, so it is a and this is the sternum, it is a retrosternal mass which is lying, so that means the mass is in the anterior mediastinum. Now CT will confirm, okay. So what you need to do to see with which so remember this thing that anterior mediastinal mass will be lying retrosternal, in the retrosternal position, and posterior mediastinal mass will be lying over the, it will be like they will be seen as they are overlying on the spine, and the medial mediastinal mass will be somewhere here. So if you draw lines of the atomic classification or the Felsen classification, it will be like this. So this is the anterior, this is the medial, and this is the posterior mediastinal compartment, okay. So let's read downside. So the mass is in the middle mediastinum because of obtuse angle. The silhouette of the right hilum vessels is not obliterated by the mass. The mass is therefore either in the anterior or in the posterior mediastinum. On the lateral chest X-ray, there is obliteration of the retrosternal space. The mass is therefore in the anterior mediastinum. Now the CT shows the precise position of the well dilated mass located in the anterior mediastinum. See in the CT. So this is the anterior mediastinum mass, okay. Its relationship to the pulmonary artery, and it contains fat. So what is the content? It is fat because it is light gray in color. Light gray. Fat is light gray in color. So it is light gray, that's why it is fat. So blue arrow, this one. So this is the fat, okay, light gray in color. And fluid, green arrow. So this is the fluid, fat and fluid, okay. I will just clear it, sorry. So this is fat, light gray in color, and this is fluid, dark gray in color, okay, bright gray you can say, light gray and bright gray, and this is calcification, this red arrow, calcification, white in color, okay, white in color. So three opacities you are able to see. So this is fat, and this is water, and this is calcification, rim like calcification. So suggesting the diagnosis of mature cystic teratoma. So anterior mediastinal mass, 4 T's: thymoma, thyroid, teratoma, and terrible lymphoma. So it is a teratoma, okay. So CT scan will help us to clear the thing. So remember this thing, CT is used for the following purposes in the mediastinal masses. So first one is accurate localization of a mediastinal mass, precise assessment of the contents of a mediastinal mass like fat, calcifications, any teeth, air, fluid, or solid tissue, assessment of invasion, compression, or displacement of mediastinal structures like trachea, superior vena cava, heart, vertebral column, and biopsy under CT guidance. So these are the uses of CT scan in mediastinal masses. So that was about the anterior mediastinal masses, which was teratoma. Let us move on to this chest X-ray. So remember this, I said no, this is according to atomic classification. This is not due to, so this is atomic classification. Okay, this is the anterior compartment, this is the middle compartment, and this is the posterior compartment. So mnemonic for anterior masses is thymus, thyroid, terrible lymphoma, and teratoma, germ cell tumor. So remember these points. Signs of anterior mediastinal masses on chest X-rays: displaced anterior junction line, retrosternal space obliteration. This is very important. Okay. Cardiophrenic angle is obliterated. Cardiophrenic meaning heart and diaphragm angle is obliterated. Heart and diaphragm is obliterated. This is also important point. And there will be hilum overlay sign because it is a mediastinal mass. Hilum overlay sign will be there. What is that hilum overlay sign? The vessels will not be obscured. The vessels will not be obscured by the mass. So that means the mass is present in the anterior mediastinum, not in middle mediastinum. Okay, that is the hilum overlay sign. Two types of hilum overlay sign. Either the mass will obscure the vessels, hilar vessels, or it will not obscure. When it obscures, it is in the middle mediastinum. But when it doesn't obscure the vessels, then it is either in the anterior or posterior mediastinum. That is confirmed by lateral chest X-ray and CT scan. Now you see here. So okay, everything is okay, but you can see in the middle side, no? So you are able to see a sharp delineated. This is the right paratracheal stripe and this is the left paratracheal stripe. So both are enlarged. Both are enlarged. So this is known as this is called the mediastinum is enlarged. The width of mediastinum is increased. This is known as mediastinum enlargement. Okay, mediastinal enlargement. Okay, now you see the mass is again, it is making an obtuse angle, and it is, I think so, obtuse angle means it again, it is a mediastinal mass, and mediastinal mass, yes, it is obtuse, approximately 180 degrees. It is more than what do you call, once very much approximately 180. So it is obtuse angle. Okay, so now next is, you see the left hilar. If you see, then you are able to appreciate that the mass is not obscuring the, these are nothing but the vessels. Okay, it is not obscuring, I think, the hilar vessels. That means the hilum, that means the mass is not in the middle mediastinum, either it will be in the anterior mediastinum or in the posterior mediastinum. So let's see in the lateral chest X-ray, and after that we will analyze whether we were right or wrong. So the important sign of anterior mediastinal mass is the retrosternal cardiac space will be obliterated, as you can see here, and the cardiophrenic angle will be obliterated. Both you are able to see here. See, this is the retro sternal space, and the cardiophrenic angle also is obliterated. That means the mass is in the anterior mediastinum. It is in the anterior mediastinum mass. So anterior mediastinal mass is the diagnosis. Okay, so let's see the CT scan of that. So CT is the mainstay for diagnosis in most cases. Chest X-ray does not allow distinction between the different types of mediastinal masses. So same thing here. There is mediastinal enlargement on the PA chest X-ray, obliteration of the retrosternal space, pink asterisk on the lateral chest X-ray, hilum overlay sign on the PA chest X-ray, axial CT image obtained prior to biopsy confirms anterior mediastinal origin. Note posterior displacement of mediastinal compartment structures by the tumor, green asterisk. Okay, ascending aorta, left pulmonary artery is pure. Okay, so biopsy revealed it as a non-Hodgkin lymphoma, terrible lymphoma, the fourth T. So it was a non-Hodgkin lymphoma. Okay, so you can see this in the CT scan. This is an anterior mediastinal mass. Okay, and it is displacing the superior vena cava, ascending aorta, okay, left pulmonary artery. All these are displaced by this mass. So biopsy done, revealed lymphoma, diagnosis of lymphoma. So that's about the anterior mediastinal mass. So lateral chest X-ray and PH X-ray will reveal. And there is one more thing you found here is there is enlargement of the uh, mediastinum, mediastinal enlargement, because there is increased width of both left and right paratracheal stripes. These are the paratracheal stripes. Moving forwards, so let's see about the middle mediastinal masses. So as you know, in the middle mediastinal masses, first we'll read this thing. So the causes are lymphadenopathy, most common, vascular like aneurysm from the aorta pulmonary artery, and congenital cyst and hiatus hernia. These are the most common. 1, 2, 3, 4. Other things can be from the visceral structures of the middle mediastinum. What are the visceral structures? It can be from trachea, tumors of trachea, or bronchi, or heart, pericardium, vagus nerve, phrenic nerves, or esophagus. So these are all the mediastinal structures, visceral structures, important structures which are present in the middle mediastinum. Common things are lymphadenopathy, vascular mass like aneurysm, congenital cyst like bronchial, esophageal, pericardial cyst, and hiatus hernia. Okay, so hiatus hernia and lymphadenopathy, aneurysm, and congenital cyst. These are the common differential diagnosis. What are the signs of middle mediastinal mass on chest X-ray? So remember, there will be no hilum overlay sign. No hilum overlay sign meaning the hilum, the vessels will be obliterated. The hilar vessels will be obliterated by the mass. The hilar vessels will be obliterated by the mass. So we will not be able to distinguish the hilar vessels which in the left carina from the mass border. The hilar silhouette is present. Hilar silhouette sign is present here. So hilar silhouette sign is present. That's why hilum overlay sign is absent. And you will find widened paratracheal stripes as you seen in the previous chest X-ray. And this one, convex aortopulmonary window. Okay, this is important because aorta and pulmonary arteries are present in middle mediastinum. That's why it will be convex. Mass anterior to the spine on chest, lateral chest X-ray. So in the lateral chest X-ray, if you see, the mass will be anterior to the spine. Definite sign with the left or right bronchus on a lateral chest X-ray. Okay, so this is important, this is important, this is important, this is important, and definite sign. Okay, remember all these things you will see. In the anterior mediastinal mass, the cardiophrenic angle will be lost. The most important, most important is in the lateral chest X-ray is the retrosternal space will be obliterated. That is the most important sign. So now let us see the X-ray here. Again, now you are able to see here the mediastinum is enlarged. Okay, the mediastinum is enlarged here. And now see here, this is the aorta and this is the pulmonary artery, and there is convex opacity you can see here. So there is enlarged aortopulmonary window. So that means the mass is in the middle mediastinum. Okay, and what is the mass? Means whether it is mediastinal or lung mass. So the angle is 180 degree. So it is obviously obtuse angle. So it is a mediastinal mass. And what are the clues that it is in middle mediastinum? What are the clues? The clue, this aortic pulmonary window is enlarged. There is mediastinal enlargement that can be seen in anterior middle mediastinum mass that we leave. Now you see here, you are not able to make out the vessels here. You are not able to make out the vessels in the right carina. Okay, and these 2 points, no, these 2 points, if you are confused with whether to make out any vessels obliteration in the hila, no, you just see the aortic pulmonary window. So if it is convex, no, then definitely the mass is in the middle mediastinum. So this is a mediastinal mass which is present in the middle mediastinum. Now let us see the lateral chest X-ray. You can see here after this, you can see here the carina and the vessels. Okay, see here the carina and the bronchivascular maskings. But here in the mass you are not able to make out. But if you have any confusion whether the whether obliteration is present or not, you are not experienced, then one sign is this aortopulmonary windows. It will be obliterated in a middle mediastinal mass. Okay, so that's only a PH X-ray. In the CT scan, that is a definitive diagnosis to make. You can see a middle mediastinal mass here, see here. And what are all you are able to see, this is water, this is, sorry, this is fat, and this is water, and this is calcification. So you are able to see fat, water, and somewhat calcifications in this same picture here. Okay, calcifications you are able to see. So let's read. PA chest X-ray showing a large mediastinum, blue arrows I said. Okay, wide right paratracheal stripe, yes it is there, it is widened. Left also it is widened. Okay, widened left paratracheal stripe, absent hilum overlay sign, absent hilum overlay sign suggesting a middle mediastinal mass. So you're not able to, your the absent hilum overlay sign, that means uh, the hilar vessels are obscured by the mass. Okay, suggesting a middle mediastinal mass, because when the mass is present in the middle mediastinum, the hilar vessels should be obscured by the mass. Contrast enhanced axial CT and coronal MIP reconstruction confirm the presence of middle mediastinum. The mass contains fatty tissue and was a lipoma surgery. I said no, this is light gray in color actually. That's why I said this is fat, and this is dark gray. I think it is water, and this white. Okay, that's what. That's what. It is mostly fat. Okay, so that is a lipoma. Okay, so that's about the mediastinal mass. So important thing in mediastinal mass is, so there will be obscuration of the hilar vessels by the border of the mass, and if you are confused about that obscuration, then you should see the aortopulmonary window. That aortic pulmonary window will be enlarged in middle mediastinum, or else you just do a CT scan and that will confirm. Okay, but this is important to, these two things are important to say that the mass is the widening of the mediastinum. This is the widening of the mediastinum, this widening of the mediastinum is very much important to suggest that there is something in the mediastinum leading to widening of the mediastinum. So widening of the mediastinum, you should catch that thing. Okay, catch the widening of the mediastinum. That is also important thing to suggest that there is a mass. So one thing I will say, so whenever you're thinking of a mass, so you see the paratracheal stripes here, and you see the any sharp round like opacity which is present in the middle side of the chest X-ray, sharp round like opacity present, and you see the left and right paratracheal stripes. You just see, when you detect either the widening of mediastinum or some sharp border round like opacity in the middle side of the lung, then you think it as a mass, and then you apply the angle border sign and hilum overlay sign, and you perform a lateral chest X-ray. And still if you have confusion, then you go to for CT scan. So that's the easy way. Now coming to the one more X-ray. So patients with so this is actually, first we will see, then I will disclose the diagnosis. So you see the middle part of the lung to see a mass. Okay, so carina is okay. Okay, aortic pulmonary window is not obliterated. Okay, it is good. This is the aorta. Okay, mediastinum is not widened. Okay, but in the lower part you just see there is a opacity like this. You're saying, you're able to see, are you able to appreciate this one, this border, okay, so this border, this one from here to here, so there is a mass in the mediastinum. Okay, whenever the mass is present in the lower part of the chest X-ray, mostly it is hiatus hernia, okay. Now in the lateral chest X-ray, see the mass is posterior, this is the heart shadow. Okay, the mass is posterior to the heart, but it is anterior to the spine. That means the mass is in the middle mediastinum. No hilum overlay sign, angle border sign, nothing you are able to see here. Okay, So that is the diagnosis. In PH chest X-ray, and lateral chest X-ray showing a retrocardiac middle mediastinal mass partly projecting below the diaphragm. Okay. So axial contrast and CT coronal sagittal reformated images show a sliding hiatus hernia, okay, with gastric fundus green arrows extending well above the diaphragm. This one. Whenever you see a circle like thing in the lower side of the middle of the chest, it is mostly hiatus hernia. Okay. So patients with hiatus hernia can be entirely asymptomatic, in which case hiatus hernia is an incidental finding. Okay. In minimally symptomatic and in older patients, watchful waiting is recommended. Okay. Minimally symptomatic and in older patient, watchful waiting is recommended. Symptomatic hiatus hernia, especially the rolling, the mixed types, and the hiatus hernia containing the viscera, then the stomach are usually managed surgically. Now we will see this one, this X-ray. So because we are discussing the mediastinal, we will focus in the middle part of the lung. So there is no mediastinal widening here. So mediastinal widening is mostly present in the anterior and middle mediastinal masses. Anterior mediastinal masses. Okay, but you are able to see in the lower side. Okay, see this round like opacity. Okay, and a straight level you are able to opaque line you are able to draw here. If you see carefully, okay, see this is the border. Okay, this is a circle border, and here the, if you see this point, okay, this is actually air. Okay, and if this point is very white, so I think this is a fluid. Okay, so it is also a hiatus hernia only, and this is the air bubble, gastric air bubble. Okay, gastric air bubble. Now when you see in the lateral chest X-ray, you see here, this is a retrocardiac mass which has air fluid level. This is the air level and this is the fluid level. So you are seeing a mass with air fluid level. So PH chest X-ray, lateral chest X-ray showing a retrocardiac middle mediastinal mass with a gas fluid level, typical of the diagnosis of hiatus hernia. Okay, that's about the one more middle mediastinal mass. That was previous was lipoma. This is hiatus hernia. Now the posterior mediastinal mass. Now coming to the posterior mediastinal mass. Okay. So first we'll see these things. So what are the causes of posterior mediastinal masses? So mainly neurogenic tumors. Okay, neurogenic tumors. Okay, or thoracic aortic aneurysm, important infection like abscess or tuberculosis, meningoceles. Okay, mainly you remember three things we have seen in the table: neurogenic tumors, infection, spinal infection, or descending thoracic aortic aneurysm. These three things: tumors, thoracic aortic aneurysm, and infection of the spine. Okay, so what are the signs we see in chest X-ray in this one? So you will see hilum overlay sign. Hilum overlay sign is nothing but when the hilum overlay sign is present, the mass is not in the middle mediastinum. That is hilum overlay sign. The mass is not in the middle mediastinum. That is hilum overlay sign. If the mass is in the middle mediastinum, that is hilum overlay sign is not present. Okay, so hilum overlay sign will be present in both anterior and posterior middle mediastinal masses. Cardiac border can be clearly seen in these things. See, cardiac border can be clearly seen. Whereas in middle mediastinal masses, you can see cardiac, but retrocardiac something you will see in middle mediastinal mass, retrocardiac. And in anterior it will be retrosternal, and cardiophrenic angle will be obliterated. Okay, widened paraspinal and para-aortic lines, mass projecting on the spinal lateral. This is important, on the spine on lateral chest X-ray. Okay, these are the things. So these things is important. These two, hilum overlay sign and mass projecting on the spinal lateral. These two are very important to say it is a posterior mediastinal mass. Now you can see here there is a mass. We look just in the middle side of the chest X-ray, and it is making a obtuse angle again, so it is a mediastinal mass. Okay, now you can see the border here. separate border of the hila. That means the hilum overlay sign is present. Okay, hilum overlay sign is present. So the mass is not in the middle mediastinum. On the lateral chest X-ray, you are seeing a roundish structure which is lying over the spine. See, oh, this is very important sign in. And cardiac borders are okay. Cardiac borders are okay. So it is a mass which is present in the posterior mediastinum. Okay. So the mass in the middle mediastinum, the silhouette of the left hilum vessels is not obliterated. The mass is therefore either in the anterior or in the posterior mediastinum. The cardiac border is clearly seen. This is a posterior mediastinal mass. Lateral chest X-ray confirms the posterior. The cardiac border is clearly seen. The cardiac border is clearly seen. This is important. The cardiac border is clearly seen. When the cardiac border is obliterated, then mostly the mass will be in the middle mediastinum. When the cardiac border is obliterated, I repeat my point, when the cardiac border is obliterated by the mass, then the mass is mostly in the mediastinum. Okay. Lateral chest confirms the posterior mediastinal position. MRI shows a well delineated posterior mediastinal mass. Its relation to the descending aorta and thoracic vertebral bodies and multiple flow voids is in enlarged and tortuous vessels with the suggesting a paraganglioma. Surgery confirmed the diagnosis. So here is the CT scan. You are seeing paraspinal mass here. Okay, paraspinal mass. So that is another paraganglioma in the CT scan. Okay. So that was about the mediastinal masses. Now we will learn about hilar enlargement. Okay, first thing, differential diagnosis of unilateral hilar enlargement. So number one is lung carcinoma. Number two is lymphadenopathy. It can be due to infection, inflammation, or increased proliferation. That is nothing but malignancy. Okay, and the third one is enlarged pulmonary artery. Enlarged pulmonary artery. Okay, enlarged pulmonary artery due to unilateral pulmonary massive embolus, aneurysm of the pulmonary artery, pulmonary stenosis with post-stenotic left dilation. Okay, so these are the causes. So these are the causes of unilateral hilar. One more time: bronchogenic carcinoma, lymphadenopathy due to three eyes, and enlarged pulmonary artery, not relating to aorta here. Okay. So let us see here. So you are able to see this is not a mass actually. That to differentiate from a mass, I said mass will have a smooth round counter and the opacities it will have a smooth round counter. But here you will not able to see smooth round counter. You will see fluffy opacities which are coalescing with each other. Fluffy opacities which are coalescing with each other. So you will see it as filling of the hila. You will see it as filling of the hila. See here, there is filling of the left hila, and this opacity is very well separated from the hard border and confined to the left hila, and the bronchovascular markings are marching towards this hila. So this is a unilateral hilar enlargement. Unilateral hilar enlargement. So most common cause of unilateral enlargement are these. Okay. Now what bilateral? This is an example for bilateral hilar. You can, this is, I said no, there will be no smooth and soft round border here. To differentiate it from mediastinal mass, it will not have any smooth or soft round border here, and it will be confined to the hila, and it will be fluffy opacities which are coalescing, which coalesced fluffy opacities like thing you will see filling the hila. So these are nothing but, this is a picture of bilateral mediastinal enlargement. Okay. So what are the differential diagnosis? So bilateral, most common, remember, it is Hodgkins lymphoma and sarcoidosis. Very important. Bilateral is number one is bronchogenic carcinoma. Second is lymphadenopathy. Okay, and star is the most common cause. See, it is sarcoidosis and pulmonary arterial hypertension. So these two are the most common causes of bilateral hilar enlargement. Pulmonary arterial hypertension and sarcoidosis are the most common cause of bilateral hilar enlargement. And unilateral bronchogenic carcinoma and primary non-lung primary neoplasms, tuberculosis. These three are the most common cause of unilateral hilar enlargement, lymphadenopathy mainly. So it is lymphadenopathy and carcinoma are the most common. And here it is sarcoidosis and pulmonary arterial hypertension. These are the most common causes of bilateral hilar enlargement. In sarcoidosis, you will see a sign known as 1, 2, 3 sign. So we will discuss that. 1, 2, 3 sign. See here it is bilateral. By seeing only you can make out. So bilateral hilar enlargement, you are able to see there is no cardiomegaly. Okay. Okay. Bilateral hilar enlargement is there. One more thing you are able to see here is you are able to see the right paratracheal stripe is enlarged, a bump here. So this is, sorry, not this. So right paratracheal stripe is enlarged. It can be a mass, but it is not mass. So it is right paratracheal lymphadenopathy combined with these three. So this is like this. So this is known as some sign. Okay. What is that sign? 1, 2, 3 sign or Pawnbroker sign. Okay. The combination of right paratracheal nodes, right and left hilar nodes is also known as the Pawnbroker sign or the 1, 2, 3 sign. 1, 2, 3 sign. Commonly seen in sarcoidosis. And also seen in lymphoma, but to differentiate between lymphoma and sarcoidosis, in sarcoidosis it will be symmetric, in lymphoma it will be asymmetric, and you will confirm it was CT scan as shown here. Okay. So the last one, again you are seeing bilateral hilar enlargement here. Bilateral hilar enlargement, there is no mass, it is not, it does not have any confirmation, it is not a mediastinal mass actually. Okay. So bilateral hilar enlargement you are able to see, but along with that you are not able to see any right paratracheal stripe enlargement or something like that. Okay. So bilateral involvement is more common in Hodgkin lymphoma than in non-Hodgkin lymphoma at initial presentation. Shows bilateral enlargement of the hilar. Okay. They have done a PET CT image at the level of hilar, shows strongly FDG with enlarged lymph nodes. Histology revealed Hodgkin's lymphoma. Okay, it was Hodgkin's lymphoma. So that is an important diagnosis in bilateral hilar enlargement. So 3 important diagnosis of bilateral hilar enlargement are: number one is the sarcoidosis, most common, which where you will see Pawnbroker signs 1, 2, 3 sign. Number 2 is pulmonary arterial hypertension, and number 3 is the non-Hodgkin lymphoma. Okay, so that's about the unilateral and bilateral hilar enlargement. So we have learned what we have learned. Just to summarize, we have learned about the anterior mediastinal masses. So what will be the signs? So the hilum overlay sign will be present, angle border sign will be obtuse, and in lateral chest X-ray there will be obliteration of the retrosternal space. That is the most important sign, and sometimes obliteration of the cardiophrenic angle. Okay. In the middle mediastinal mass, the hilum overlay sign will be absent, and you will have convex opacity of the aortic pulmonary window, and the mass will be pushing the structures which is present in the visceral media, in the middle mediastinum, that is heart, aorta, all these things you will see. And there will be, and one more point is, in anterior and middle mediastinal masses you can see enlargement of the right and left paratracheal stripes. Right and left paratracheal stripes. That is one thing. Okay. Then in the posterior mediastinal mass, in the lateral chest X-ray, the mass looks like it is falling, or it is upon the spine. It is upon the spine. That is the most important. And the cardiac border will be in the PH chest X-ray. Cardiac border will be seen separate to the mass. And we have seen the X-rays of hiatus hernia, which is a common cause of posterior mediastinal mass. Okay. And also we have seen a neurogenic tumor paraganglioma mass in this video. That's in the process. And unilateral hilar enlargement you have seen, and the common cause of unilateral hilar enlargement, that is nothing but most common is lymphadenopathy. In lymphadenopathy, most commonly pulmonary carcinoma, tuberculosis, and pulmonary tuberculosis and malignancy. These are the most common causes. Bilateral enlargement we have seen. Okay, and the common cause we have seen: sarcoidosis and enlargement, pulmonary arterial hypertension, and non-Hodgkin lymphoma. So these things we have learned. So in the next class, will be on pulmonary edema, stage by stage. We will learn. Thank you.